Hello, my name is Lauren Palmier. I'm a 2014 Pharm.D graduate from UHSP and a 2021 Masters of Science graduate specializing in medical cannabis science and therapeutics from the University of Maryland, Baltimore this last year. Today, I'm going to be presenting on medical cannabis for pharmacists. My current role is as a pharmacist in charge for a local pharmacy and also as an adjunct professor at UHSP. I have no disclosures or conflicts of interest to report. The outline for today's program, we're going to talk first about the history of cannabis in the United States. We'll also talk about the endocannabinoid system. We'll talk about components of cannabis, pharmacokinetics and pharmacology of cannabis, therapeutic uses of cannabis, and current law and policy. The objective for today's presentation is for you to understand the basic history behind cannabis prohibition in the United States and the events leading up to its scheduling as a Schedule I substance. I hope for you to understand the endocannabinoid system in the human body and define the differences between a CB1 and a CB2 receptor. I hope that you can understand the basic components of cannabis and its pharmacokinetics. I would hope that you can understand the adverse effects, dosing, and delivery methods of cannabis, that you have familiarity with conditions for which cannabis may be effective, and that you understand Missouri's law regarding medical cannabis use and can gain sufficient understanding of Amendment 2. So first, we'll talk about the history of cannabis in the United States. The medical system in the 19th century was very unregulated. Very little standardization was given to medical procedures or medicinal treatments. The government and medical community realized there needed to be a change to improve the quality and delivery of medicine and medical products. In response to this need, Congress passed the Federal Food and Drug Act in 1906. A drug, in the law's eyes, was any substance defined in the U.S. Pharmacopoeia, and cannabis had its own chapter up until 1942. The Federal Food and Drug Act did not necessarily outlaw cannabis. Essentially, it allowed the Agriculture Department to put standards in place to ensure its safe use. But in 1930, many changes were seen in the United States as the government continued on its trend of regulation. The Bureau of Chemistry, which was the government's most authoritative drug regulator, became the FDA in 1930. And also in 1930, the Porter Narcotic Bill was passed, which gave the Bureau of Narcotics power of law enforcement jurisdiction over the control of narcotic drugs in the United States. 1930 also saw the emergence of politician Harry Anslinger. President Herbert Hoover selected Anslinger to serve as the commissioner of the newly formed Bureau of Narcotics. He was known for enforcing laws banning alcohol under Prohibition. But this new appointment allowed him to transfer the criminalization of alcohol use to other substances. He was especially interested in cannabis. He would travel the United States giving speeches to police groups, civic organizations, and other groups detailing why cannabis should be denounced. He particularly liked to focus on the groups that composed the temperance movement during Prohibition. He painted cannabis to be the substance that was just ruining the moral fabric of America, breaking up families and making citizens lazy and not wanting to hold down a job. He would write essays where cannabis use was the cause of different things like rape, murder, and burglary. He liked to focus on racism, often blaming immigrants from Mexico for cannabis's widespread use and availability in the United States. Harry Anslinger strongly supported the passage of the Uniform State Narcotic Act of 1932, which pushed states to unify their narcotic laws and to include cannabis under the narcotic designation. The act included criminal punishments for those violating the laws at the state level, but Anslinger wanted more done at the federal level, so he pushed Congress to pass the Marijuana Tax Act of 1937. This act required anyone who imported, manufactured, produced, and sold cannabis to register with the government and purchase a tax stamp. If someone did not comply, they could be imprisoned. And this is the most early example of the US government's effort to criminalize behavior involved in cannabis production. Additionally, Harry Anslinger was able to have the Boggs Act passed. And this act set mandatory minimum prison sentences for drug law violators. And then also, he was able to have the Narcotics Control Act passed, which then increased those penalties set by the Boggs Act. In 1970, the Controlled Substances Act formalized drug scheduling here in the United States. And in this act, cannabis was classified as a Schedule I substance, a classification it still holds today. And as most of us know, a Schedule I substance is a substance with no currently accepted medical use in the United States, also with a lack of accepted safety for use under medical supervision and a high potential for abuse. And other substances that are also grouped with cannabis in this schedule include heroin and LSD. During Richard Nixon's presidency, Nixon took a tough stance on drugs. He made cannabis use to be, quote, a problem of the minority populations and something white citizens should fear. Nixon said, quote, America's public enemy number one in the United States is drug abuse. In order to fight and defeat this enemy, it is necessary to wage a new all-out offensive, and thus the war on drugs commenced. Later, during Ronald Reagan's presidency, he continued this war on drugs by creating the Drug Abuse Resistance Education Program, also known as the DARE program. And he also created the Partnership for a Drug-Free America. Both of these organizations and programs were still targeting cannabis use specifically. This type of thinking and regulation, mostly fueled by fear and racism, continued into the 1990s and early 2000s, but we are starting to see changes in these views currently. Okay, so just a little bit of a clarification. Marijuana versus cannabis, what's in a name? So both terms refer to the same plant, a plant used for recreational or medical reasons with a THC value of greater than 0.3%. But as we've learned in the previous slides, the word marijuana has a heavy history seeded with racial undertones. It's thought that US newspapers published articles referencing, quote, Mexican marijuana and its devilish effects just to stir up anti-Mexican sentiment. Other races have also been targeted with similar attacks. Cannabis is really the preferred term. It describes the plant's scientific name, for example, Cannabis sativa or Cannabis indica. And cannabis is also the preferred term of professionals working in the industry today. You'll only hear me refer to what you know as marijuana as cannabis in this presentation. So next, we're going to talk a little bit about the endocannabinoid system. So in the cannabinoid system, there are two main receptors. The endocannabinoid system is found throughout each human body. These two main receptors are known as CB1 and CB2 receptors. When cannabis is consumed, the components of cannabis, like THC or CBD, for example, bind with these receptors to create their effect. THC binds to the CB1 receptor, which is located in the brain and in the central nervous system. This binding of THC to this receptor is why we see psychological effects with cannabis use, like euphoria, dizziness, and so forth. CB2 receptors are located mostly outside of the brain and in the periphery. When components of cannabis bind with these receptors, we see the other benefits of cannabis, like decreased inflammation, improvement in GI disorders, and so forth. So this visual shows common locations in the human body for CB1 and CB2 receptors. The light pink circles represent CB1 receptors, and as we can see, these are located mostly in the brain area. The darker maroon color represents CB2 receptors, which we can see are more located throughout the body, especially around the digestive tract. This image also explains the benefits of cannabis's interaction with these receptors, including positive effects on the central nervous system, gastrointestinal system, and immune system, as well as helping with the functioning of bone regulation, metabolism, muscle regulation, and hormone function. And I will leave this on the screen for just a little bit so you can kind of read through each of those on your own. Okay, so the endocannabinoid system continued. Cannabinoids are the components of cannabis. We also have naturally occurring cannabinoids in our body. Cannabinoids found in external products like cannabis are called exogenous cannabinoids, while those found naturally occurring in the human body are called endogenous cannabinoids. Both endogenous and exogenous cannabinoids exert effects on the body to maintain homeostasis and produce medical benefit by interacting with the CB1 and CB2 receptors. Examples of endogenous and exogenous cannabinoids are listed on the slide. So now we're going to do a quick knowledge check. So blank receptors are found mostly throughout the brain, while blank receptors are found predominantly throughout the periphery. Your choices are A, CB2, and for the second choice, CB1. Next answer would be CB3, and for the second blank, CB1. Your third choice for the first blank, CB1, and CB2 for the second blank, or CB1 for the first and CB3 for the second. The answer is C. CB1 receptors are found mostly throughout the brain, while CB2 receptors are found predominantly throughout the periphery. So CB1 receptor is found predominantly in the brain, as we went over. THC has the greatest affinity for these receptors, which again is why we see psychological adverse effects from cannabis use. The CB2 receptor is predominantly found throughout the periphery, and the CB3 receptor is not part of the endocannabinoid system. So those answers would not be correct. That included CB3. So now we're going to talk a little bit about the components of cannabis. A cannabis plant contains 480 natural components, of which over 60 components have been classified as cannabinoids. So there's major cannabinoids, which are things we've probably heard of and already touched on so far in this presentation. So THC is an agonist, or it activates CB1 and CB2 receptors. But primarily we know that THC likes the CB1 receptor, primarily responsible for the psychoactive effect of cannabis. But we also see a little bit of anti-inflammatory and neuroprotective activity from THC as well. CBD is also a major cannabinoid, but it has low affinity at CB1 receptors. So with CBD use, you typically will not see those psychoactive effects. Its activity mostly takes place at the CB2 receptor and other biological symptoms. And it's actually thought too that sometimes CBD can alleviate those psychoactive components of THC. So other minor cannabinoids that are really kind of starting to come to the forefront, and you may have heard of some of these. THCA, CBDA. So these are kind of the precursors to THC and CBD. They're found in the raw, unheated, kind of natural state cannabis plant. When they are heated and extracted, that's when our THCA and CBDA converts to THC and CBD respectively. These components on their own, before heat and extraction, are really shown to have little psychoactivity, if any, but potentially may have some other positive effects. But there are currently studies underway looking at those two components. CBG, CBC, and CBN are other minor cannabinoids that are currently being targeted, looking at their effects and the potential for treatment with these. Less is known about these compared to CBD, but there is thought to be some analgesic activity, anti-inflammatory activity, potentially some effect for appetite stimulation with these minor cannabinoids. Another component of cannabis, and an important component, is terpenes. So, cannabis produces more than 200 terpenes, but only around 30 in significant quantities. These components are pharmacologically active and they work synergistically with cannabinoids. So, one thing you may hear kind of in the world of cannabis is something called the entourage effect. So, this is a really important concept regarding the actions of cannabis. It's thought that all parts of cannabis, including cannabinoids like CBN, CBG, THC, terpenes like the ones on the screen, and other parts of the plant all work together to produce their medicinal effects together compared to that of the effects you see with just one component. So terpenes often play a role in how different cannabis strains get their name, a lot of times by the different smells. So, for example, you'll see limonene on the screen here. You might find a product at a dispensary called Lemon Haze, and most likely that will have a terpene called limonene in it. So these are fragrant compounds. They're thought to interact with the serotonin transporter system in the body to help increase levels of dopamine, norepinephrine, and serotonin. Also thought to have anti-inflammatory activity, potential anti-tumor activity, neuroprotection, and other benefits. So as you kind of read through those, you'll see like pinene, we're going to have probably a plant or a substance that has an aroma of pine trees. Limonene, again, citrusy, found in lemons. It's one that, like I said, a lemon haze might have a limonene terpene in it. And it's very common that some preparations, different cannabis preparations, have more than one terpene in them to get the different varieties. So I'll let you kind of read through that slide to get a little more information on terpenes. And like I said, there are over 30 that are more common that we see. And so this is just kind of the tip of the iceberg and some of the more common ones that you might hear or see in a dispensary. And again, here is 5 very popular cannabis terpenes and some of their benefits. So you'll see some you just saw on the previous slide, like the limonene or the pinene. And also, too, all the way to the right on the column, it'll explain strains that have these terpenes. So one thing that I thought was really interesting that I've learned is that strains that contain certain terpenes often differ on their name depending on the geographical region. So, for instance, the name Special Kush could be a name of a cannabis strain. But if you purchase that here in St. Louis, it might have a completely different composition than if you purchased it, say, in Washington State. So important to know that with strains, they can differ. So it's always important to know that even though the strain is, let's say, lavender or LA confidential, as you see under linalool, that necessarily is not going to be the same here in Missouri that it is if you're going to purchase that or recommend that to a patient in a different state. So next, we're going to talk a little bit about the pharmacokinetics and pharmacology of cannabis. So ADME, focusing on absorption, distribution, metabolism, and excretion. So absorption of cannabis depends greatly on the administration route. This will be discussed in further slides, but just know that the amount of cannabinoids absorbed depends on if the cannabis is smoked, orally ingested, etc. There are many, many application routes for cannabis, and that will affect its absorption. As far as the distribution of cannabis, so about 90% of THC binds to plasma proteins, while 10% is unbound, and that is what can bind to the CB1 receptors. THC is highly lipophilic and it readily crosses the blood-brain barrier where it binds to those CB1 receptors, and that is why we see those psychoactive effects. Metabolism of cannabis is important when speaking about the oral route. When cannabis is ingested orally or eaten as an edible, it enters the GI tract and is metabolized by the liver, just like many medications. We'll talk more about drug interactions later, but it's important to remember that orally consumed cannabis is metabolized by the cytochrome P450 system. Metabolism of cannabis is also important to understand because of the psychoactive metabolites produced after it is metabolized to the liver. We'll also discuss this on the next slide. Lastly, too, with metabolism, it's important to know that patients with liver issues like liver failure may not be the best candidates for oral cannabis formulations due to its dependence on the liver for metabolism. As far as elimination goes, the half-life of THC for an infrequent user is about 1 to 3 days. For frequent users, we are increasing to about 5 to 13 days. It's excreted about 30% in the urine and 70% in the feces. So now we'll talk a little bit more about the pharmacokinetics of THC. So as we kind of touched on in the last slide, cannabis experiences the first past effect when taken orally. It has 3 major active metabolites when it is metabolized. So delta 9 THC, which is usually the more common thought of metabolite when we're thinking of THC, is one of its metabolites, and it has a psychoactive effect. 11-hydroxy THC is also produced, and that also has a psychoactive effect. What's really important to know is that 11-hydroxy THC has a very, very, very potent effect when it is produced. So 11-hydroxy THC is 3 to 7 times more potent at CB1 receptors compared to THC or delta 9 THC on its own. And you can see the ratios there as far as the consumption goes. Smoking THC, there's about, if you smoke cannabis, the THC to THC hydroxy THC ratio is about 10 to 1. But then when you orally consume it in terms of an edible, that ratio becomes about 1 to 1. The psychoactive effects of the 11-hydroxy THC last longer and fade slower after an oral dosing. Those effects can be intense and long-lasting. So it's very, very important when counseling patients that are deciding to use the oral route of cannabis to know that while they may not see an effect right away, there will be an effect later, and this effect can be very intense depending on the amount consumed. So the amount consumed with oral products, that's definitely a big counseling point for patients to ensure that they know you may not feel something right away, but there will be an effect later, so they should not consume more than the recommended dose trying to feel an effect, because they will eventually feel an effect due to this psychoactive metabolite of the 11-hydroxy THC. There's also 11-carboxy THC, which is another major active metabolite of cannabis, but it has no psychoactive effect. So when we're looking at the delta 9, the hydroxy, and the carboxy, really that 11-hydroxy THC is what we're most concerned about, because that is where we're going to see the most psychoactive effects after a patient consumes cannabis. So talking about dosing strategies, common school of thought, kind of like I touched with the edible preparations, is start low and go slow. So repeated doses of cannabis and THC can cause the brain to reduce the density of cannabinoid receptors in the body, meaning a patient is going to need more cannabis or THC to feel the same effect. So really, you do want to start low and go slow. The minimum effective dose is what we always want to start with and go with, because we can always build from there. Typically, doses for especially a cannabis naive patient, we're going to start around 2 or 2.5 milligrams. And usually in most patients, especially those who are frequent users of medical cannabis, going up to about 10 milligrams of THC will be enough to address their symptoms. At 15 milligrams of THC, you may see levels of intoxication beginning, especially in a naive patient. In a naive patient, I would start no higher than probably 2 or 2.5 milligrams. If a patient does seem to be experiencing tolerance issues because maybe they are someone who's using 10 milligrams consistently every day, you can typically reverse that with a period of abstinence. So anywhere from a few days to longer, depending on the duration of the patient's previous cannabis use, will typically help to reduce some of that tolerance that they may see. Now we're going to talk a little bit about cannabis delivery mechanisms. So, smoking is probably the most common method that we see and hear about. This causes rapid elevation of THC levels in the bloodstream. And this really does kind of give patients some control over the dosing because they can titrate their dose one inhalation at a time, waiting a few minutes in between each dose, and then kind of basically increasing themselves until they are at the effect they want. Vaporization really does help to deliver terpenes and cannabinoids to the bloodstream just as quickly as smoking, but there is a little bit of risk for over medication. So, vapor is usually more easily tolerated by patients compared to smoke. So, if you think about even with cigarettes, smoking versus vaporizing nicotine products, usually the vapor is more tolerable. So unknowingly, they may actually inhale more and hold it in the lungs for longer than intended, which may lead to a higher dose consumed than intended. So it's really important to educate patients who are going to vapor or use vaporizing as their delivery mechanism about this so that they do not overmedicate themselves. So sublingual or buccal administration gives a better delivery of terpenes overall. When the terpenes or the cannabis product is heated in smoking and vaporizing, the overall delivery of terpenes is less. The heat basically breaks these down, and while a patient may still get some, they're not getting the full benefit that they would if they would not use a mechanism that did break those down. So dosing, as we know, occurs beneath the tongue or applied to the buccal tissues. And starting dose here, again, we want to start patients at about 2.5 milligrams, 2 or 2.5. Um, Sublingual, as we know, this administration avoids metabolism by the liver. So the cannabinoids are absorbed through the blood vessels beneath the tongue and or in the cheek. Oral administration, like we've touched on previously, gives an increased duration of medicinal effect. So, out of all of our options, this is the one delivery mechanism that's going to give the longest effect of cannabis. Kind of a rule of thumb that is used by many is that an orally administered cannabis product will deliver an effect that lasts twice as long as smoked cannabis. But there is a potential for over medication here due to variability, so variability of the product, and also patients themselves over medicating if they feel that they are not getting an effect right away, which they will not with this kind of route. So that's important for patient education. There are topical applications available with cannabis products. Thought that the main benefit here is the anti inflammatory properties to help with conditions like eczema or psoriasis. There's also rectal and vaginal suppositories available. So again, these are going to bypass liver metabolism and the digestive tract altogether. You can also formulate these to be time release. So while maybe not the most pleasant route of administration, there may be some cases where this is going to be best for your patient. So talking a little bit about onsets of action. So for smoking and vaporizing, inhaled THC in cannabis reaches peak blood plasma concentrations within 5 to 10 minutes of ingestion. THC is detectable in blood seconds after inhalation, and this is going to be our fastest onset compared to other routes. And the efficacy and efficiency of inhaled cannabis is really dependent on the size and duration of inhalation. So important to counsel patients about their inhalations. Are they inhaling deep and holding for a long time, or is it a quick inhalation and a quick release? This is all going to impact the dose that they are receiving. Sublingual and buccal administration. So this is absorbed directly into the bloodstream. You can see an onset of action as quickly as 5 to 15 minutes after use, with a peak blood plasma concentration in about 45 minutes to 2 hours. Oral administration. So this is slow and inconsistent absorption due to differencing in patients' metabolisms, essentially. Everybody is different with how fast they metabolize different things, and that's no different with cannabis. So onset typically can be anywhere from 30 minutes to 2 hours. Maximum peak blood plasma level in 2 to 7 hours. So this is going to be effective for 2 to 3 times longer than smoked or vaporized cannabis. And again, patients should be counseled to not repeat an edible dosage if they do not feel effects right away. It's variable with how quickly a person will feel an effect, and it's important that they do not accidentally consume too much cannabis or THC. Due to its duration being 2 to 3 times longer than inhaled cannabis, edible cannabis's dosing frequency must consider this and adjust accordingly. Additionally, terpenes are typically destroyed when cannabis is consumed orally due to stomach acid and digestive enzymes. So it's kind of important to keep that in mind too when you're thinking about the entourage effect that we discussed earlier. They may not be getting the full benefit of the plant in this type of administration. For topical applications, relief of topical conditions is typically seen quickly, but it can be difficult to predict systematic onset of action due to inefficiencies in absorption through the skin. So everybody's skin is kind of different. As we get older, our skin thins. Some people do have thicker skin. Depending on the condition you're treating, it really can vary person to person how quickly we see relief and how long we see relief. And for rectal and vaginal suppositories, the onset is very similar to the buccal and sublingual route of administration. So, cannabis does come with its own range of adverse effects. So, there's kind of two different ways to look at the adverse effects of cannabis. There are short term adverse effects, and there are long term adverse effects. So, short term adverse effects would include things like confusion, anxiety, feelings of panic. And these are typically dose dependent adverse effects, so a lower dose of THC may help relieve these symptoms. Tachycardia, so we know that as an increased heart rate, that typically will subside in about 15 to 20 minutes. But if you do have a patient who is suffering from this fast heart rate when they use cannabis, you can encourage them to do slow and steady breathing, which may help. But of course, if a patient has any chest pain or other cardiac symptoms, they should call 911. Red and irritated eyes is often something we see short term with cannabis use, and that can be relieved with artificial tears. Coughing is common, especially if the cannabis is inhaled. That will usually subside on its own, or a patient can try to drink water to relieve it. If the cough is persistent or bothersome, the patient may want to try a different route of administration. And dry mouth is often something we see with cannabis use, and that can be relieved with citrus products like citrus lozenges or lemonade to help encourage saliva production. Some long-term effects that we can see with cannabis use include chronic and severe bronchitis in long-term smokers and potential for cognitive deficits in long-term heavy consumers. So some safety concerns around cannabis. Patients may be at risk for additional adverse effects or worsening of current conditions if they have any of the following conditions. Things like schizophrenia, bipolar, or severe depression, heart disease, and heart disease is an important one, uncontrolled or untreated high blood pressure, angina or chest pain, irregular heartbeat, or history of stroke. Typically, a patient should be referred to their physician if they have any conditions that are untreated or uncontrolled. Severe psychiatric patients and or cardiac patients should especially be referred. Studies have shown cannabis to have a biphasic, bidirectional effect on psychiatric issues, meaning cannabis can improve but can worsen these conditions as well. Studies have also shown that cannabis can have an effect on blood pressure, meaning it may increase blood pressure, or a potential for an increased risk of stroke. So, cardiac patients, especially, should be seeking guidance from an educated provider before making a decision on cannabis products. As far as pregnant and lactating patients go, cannabis really should be avoided in these patient populations. There's really just not enough data present at this time for a safe recommendation. Those studies are underway, and we do know that cannabis does cross into the breast milk. So, really, this patient population should avoid its use. As far as pediatric patient populations go, cannabis can cause significant adverse effects in pediatric patients like ataxia, tremor, central nervous system depression like lethargy, stupor, and coma. And since there are such significant safety issues and we're dealing with a very sensitive patient population, Children that need medical cannabis should be referred to clinicians with experience in this patient population. And other safety concerns include adult patients who are using edible preparations should really take extra precaution if children are in the home due to the edible's resemblance of common candies and foods. Patients should be counseled to store their medical cannabis in a safe and secure place out of the reach of children and out of the reach of pets. So, drug interactions. We briefly mentioned in a previous slide that cannabis is metabolized by the cytochrome P450 enzyme system, so including enzymes like CYP2C9, CYP34A, etc. Cannabinoids either inhibit or induce or activate the activity of these enzymes. And as we know, this enzyme system is responsible for the metabolism of common medications. This interaction can either decrease or increase the effect of a medication. So on this slide, I have listed medications that increase the effects of orally administered cannabis, and also medications that decrease the effects of orally administered cannabis. Also, too, it's important to note that cannabis can increase the effects of alcohol, benzodiazepines, and opiates. So use with these substances should be avoided. Patients taking medications metabolized by the cytochrome P450 enzyme system should be counseled to separate administration of their medication from cannabis. So dependence and withdrawal. The 2015 Center for Behavioral Health Statistics and Quality report stated that 22.2 million Americans aged 12 or older identified as current users of cannabis, and about 4.2 million of those 22 million reported symptoms that would qualify them for cannabis use disorder. So just like we have opioid use disorder in the DSM-5, we also have cannabis use disorder. So symptoms of dependency might include excessive or often daily use of cannabis, tolerance to cannabis that requires an increased dose to achieve an effect, compulsion to use cannabis whenever available or offered, and withdrawal symptoms after cessation of use, and excessive time spent on trying to get cannabis. Withdrawal symptoms from cannabis will include insomnia, irritability, reduced appetite, stomach upset, nausea, moodiness, depression, and other symptoms. It's important to note that there are no documented overdose deaths from cannabis use, but some healthcare providers report seeing cannabinoid hyperemesis syndrome in the emergency rooms. At very high concentrations of THC, THC can promote dopamine or serotonin release, both of which can trigger emesis or vomiting. This is usually resolved by abstaining from THC and using supportive measures like rest, fluids, benzodiazepines, and other medications to help a patient. Okay, time for another knowledge check. So which major active metabolite of THC has no psychoactive effect? Okay, if you answered A, you would be correct. So 11-carboxy-THC is one of the three major active metabolites that has no psychoactive effect. As we talked about, 11-hydroxy-THC, so B, we know this has a very potent psychoactive effect. And we know that delta-9-THC, answer C, also produces psychoactive effects. 11-carboxy-THC is the one metabolite that we know that has no psychoactive effects. Another knowledge check. Which delivery mechanism of cannabis causes the most rapid elevation of THC levels in the bloodstream? If you said B, smoking, you would be correct. Because smoking cannabis bypasses the metabolism and enters directly into the bloodstream, this route of administration causes the most rapid elevation of THC levels. Oral administration must undergo metabolism by the liver and has one of the slowest onsets of effect. Buccal administration, while faster than oral, has a slower onset of effect compared to smoking, and topical application can be inconsistent and often levels of THC are not reached in circulation. Okay, next question. Which of the following is considered a long-term adverse effect of cannabis? So, long-term adverse effect. A, red irritated eyes, B, tachycardia, C, cognitive deficits, or D, dry mouth. So if you answered C, cognitive deficits, you would be correct. A long-term adverse effect is an adverse effect that is not quickly resolved on its own or quickly resolved with treatment. So as we learned in previous slides, red irritated eyes, tachycardia, and dry mouth are all short-term acute adverse effects and can often be relieved with cessation of cannabis use or with treatment like eye drops for the red irritated eyes, or sometimes they just resolve on their own over a short period of time. Cognitive defects may require a longer cessation period from cannabis to resolve or other interventions. Next question. Which of the following medications may increase the effects of orally administered medical cannabis? A, amiodarone, B, erythromycin, C, diltiazem, or D, all of the above? If you answered D, all of the above, you are correct. Each medication listed, so amiodarone, erythromycin, and diltiazem, are metabolized by the CYP P450 enzyme system. These medications are administered with or before cannabis. The metabolism of cannabis would be decreased, thus increasing the levels of cannabis in the body and its effects. Now we're going to touch a little bit on medical conditions and cannabis. So cancer. Preclinical cancer cell studies demonstrate that cannabinoids have anti-tumor activity. It's thought that they promote cell cancer death, and they seem to inhibit cell proliferation and invasiveness. They are thought to promote the reduction of blood supply needed for tumor growth and promote the reduction in metastases. Also, cannabinoids are known to help with adverse effects related to cancer in its treatment, such as pain, chemotherapy-induced nausea and vomiting, appetite stimulation or weight gain, and sleep. Multiple studies have shown complete resolution of chemotherapy-induced nausea and vomiting after use of cannabinoids compared to placebo. An article in the Journal of Pain and Symptom Management described how a THC and CBD ratio was shown efficacious in relieving advanced cancer pain not fully resolved with opioids. It's really important to not promise cannabis as a treatment for cancer to patients, but yet as an adjunct therapy to help treat adverse effects with the potential for decreasing tumor growth. So, epilepsy. What does the research say about THC? So THC has shown both anticonvulsant and proconvulsant effects in seizure models. Due to THC's inconsistent activity in seizure models, CBD is often the preferred agent for research. CBD has been shown to have better defined anticonvulsant profile in animal models and is considered to be effective against focal and generalized seizures. In 3 studies of patients with seizure disorders, CBD added on to a pre-existing anticonvulsant medication therapy was found to be superior to placebo in reducing the frequency of convulsive seizures in patients with Dravet syndrome and decreased the frequency of drop seizures in patients with Lennox-Gastaut syndrome. The image to the right on this slide shows the results of these 3 placebo-controlled trials looking at the results of CBD on seizure frequency. Each of these 3 studies showed statistically significant results, with CBD causing a higher reduction of seizure frequency in both Dravet syndrome and Lennox-Gastaut syndrome, which are 2 different types of epilepsy. So glaucoma. Endocannabinoid receptors are located throughout the eye. It is thought that cannabinoids can reduce the intraocular pressure seen in glaucoma. In a 1971 small study, it was shown that smoking cannabis lowered intraocular pressure temporarily, with the effect only lasting around 3 to 4 hours. Cannabinoids seem to have neuroprotective effects, leading to a decrease in retinal cell death and potentially decreasing the risk for vision loss. But cannabinoids typically are not applied directly into the eye due to formulation restrictions. So they're lipophilic and have low water solubility, making the creation of an eye drop pretty difficult. There are studies underway to try to develop effective models of administration and delivery outside of smoking. It's important to note that glaucoma often occurs in an aging population. So if we are going to recommend glaucoma for or cannabis for temporary relief of glaucoma, these patients should be counseled on the potential for an increased risk of fall or other adverse effects with THC. So migraines. Cluster headaches and migraines are thought to involve the hypothalamus, which has a high density of cannabinoid receptors. Cannabinoids have been shown as effective as a prophylaxis for reducing the frequency of migraine. In 2016, there was a review of Colorado patients with migraine, and it was noted that 39.7% of patients reported positive benefits in regards to their migraines with cannabis use. Nearly 20% of participants successfully reduced the frequency of their migraines, and over 11% of respondents said cannabis caused their migraines to completely cease. And another review in 2015, looking at medical cannabis and headaches, cases were shown that cluster headaches can be alleviated with cannabis use. An example from this review included a 19-year-old with a history of cluster headaches not relieved with prescription medication. The patient smoked cannabis at the onset of a cluster headache, and within 5 minutes, the headache would cease. So cannabis is usually seen as a popular remedy or treatment for pain. Cannabinoids have been shown to relieve pain through producing an analgesic and anti-inflammatory effect by modulating neurotransmitter release and stimulating the body's release of its own natural opioids. In vitro, THC alone has shown twice as much anti-inflammatory activity as hydrocortisone. It's thought that THC and CBD work synergistically together to produce anti-inflammatory action. So looking at different conditions categorized as a pain condition, so things like fibromyalgia. There was a 2011 study of cannabis use in fibromyalgia patients, studying the effectiveness of cannabis on reported symptoms. Patients that were studied reported significant reduction of pain and stiffness, an enhancement of relaxation, an improvement in insomnia, and increased feelings of well-being. Looking at neuropathy, there was a review conducted by the University of California comparing the effectiveness of cannabis against a tricyclic antidepressant, gabapentin, and other anticonvulsants and SSRIs, which we all know are traditional medications used in neuropathy. Cannabis proved to be more effective than all agents listed except for the TCAs. Other research supports the notion that cannabis reduces the intensity of pain felt with neuropathy. So continuing on pain, with chronic pain, there have been studies that have shown cannabis to be more effective at helping control chronic pain compared to acute pain. There was a 2011 systematic review of randomized trials showing significant pain reduction from cannabinoids in 15 studies involving 766 participants between 2003 and 2010. In a 2014 study, patients reported an average decrease in chronic pain of 64% after using cannabis. So it's really, when we talk about chronic pain, especially in patients that are using opioids, it's thought that cannabinoids may have an opioid-sparing effect, providing analgesia while allowing patients the opportunity to use a lower dose of opioids for all over pain control. So this is really important when we're thinking about those accidental overdoses with opioids and just the dangerous doses that we sometimes see with patients. If a patient can use a cannabinoid in conjunction with their opioid medication under the observation of a provider or under the direction of a provider, those patients may see themselves using less opioids. Or even getting off the opioid medication altogether, which is ultimately, as far as safety goes, while they may have an increase in adverse effects, we don't think that they would see an accidental overdose if they're using a lower dose of an opioid with a cannabinoid compared to a high opioid dose with no cannabinoid. So really here, The goal is to kind of avoid those accidental overdoses leading in deaths when we're talking about high dosed opioids alone. So, looking at multiple sclerosis and spasticity, cannabinoids are thought to be neuroprotective agents in MS, so potential for decreasing damage to axons and neurons. The cannabinoids in multiple sclerosis study, also known as the CAM study, provided evidence of significant improvement in the areas of pain, sleep, and spasticity in MS patients. There was a placebo controlled study of 30 MS patients in the University of California Center for Medical Cannabis Research, and they looked at smoked cannabis and its effect on MS pain and spasticity. Results showed a significant reduction in spasticity when cannabis was used compared to placebo, with patients reporting pain reduced on average by 50%. So now we'll briefly look at psychiatric disorders. And as we mentioned in previous slides, THC has a biphasic and bidirectional effect on anxiety, meaning it can, and other psychiatric disorders, basically meaning it can reduce or increase that symptoms of that condition. And that does depend on a variety of factors like the cannabis variety, the dose, the mindset of the patient, etc. So, with some of these conditions, you'll see us talking about this biphasic and bidirectional effect. Anxiety is one of the psychiatric disorders that does have this effect with cannabis. It's often thought that a lower dose of THC can help relieve anxiety, while a higher dose may trigger a worsening of symptoms. As far as bipolar disorder goes, cannabis is thought to calm the hyperactivity of a hypomanic or manic episode and to lift the mood during depressive episodes. Depression is another condition where we see a biphasic and bidirectional effect. So where the depression may be alleviated or where it can become worse. And it's thought that the dose of THC is what can cause this effect. So a lower dose may reduce depression while a high dose may precipitate depression. Schizophrenia is one that typically we do want to refer a patient, but cannabinoids have been shown to be effective in treating the positive symptoms of schizophrenia, like delusions. Post-traumatic stress disorder is an area where we do see a lot of promise with cannabis. There's evidence that cannabinoids reduce the body's acute response to stress, as well as its response to a perceived threat. There was a study with Israeli veterans who were consuming 100 grams of cannabis per month. And in these patients, they saw a reduction in their PTSD scale score over a year. There was also a study in New Mexico from 2009 to 2011 showing a reduction in PTSD symptoms in more than 75% of patients who were using cannabis. For insomnia, THC has been shown to be helpful due to its sedating effects. And when consumed orally, as we know, these effects become stronger and do last longer. So HIV/AIDS. A study from Stanford University, Veteran Affairs, and Harvard University showed occasional cannabis use to be positively linked to increased antiretroviral therapy adherence and relief of common HIV/AIDS symptoms, including wasting syndrome, nausea, appetite complications, and HIV-related neuropathy. There was a study in 2007 focusing on acutely ill AIDS patients, and that linked cannabis use to significantly improved appetite and increased caloric intake. A 2008 small-scale trial suggested that inhaled cannabis that was THC dominant was effective in treating HIV-related neuropathy. 46% of patients that were treated with cannabis reported relief, while only 18% of placebo patients reported relief. There's been recent studies looking at the effects of THC on the immune function of rhesus monkeys with basically their version of HIV. And it showed a decrease in monkey mortality rate and viral load. So while still under investigation, it's hypothesized that cannabis may help to increase immune cells, the CD4 helper T cells that are lost during HIV/AIDS, which will help to prevent further complications like opportunistic infections. So research is definitely still underway in looking at cannabis's positive effects in HIV/AIDS patients. So additional medical conditions that we have seen some promise with medical cannabis use would be in gastrointestinal disorders. So as we saw in that image earlier in the presentation, there were a lot of CB2 receptors really kind of collecting in the GI tract area. Endocannabinoids are thought to maintain the integrity of the epithelial barrier and regulate gastrointestinal motility and secretion. There was a study in Israel that showed a remission of Crohn's symptoms in more than half of participants who used cannabis. And patients with severe inflammatory bowel disease have noted that they've seen a reduction in frequency and severity of nausea episodes with cannabis use. Looking at Alzheimer's disease, there is a potential for increased food intake, decreased agitation, and overall decrease in symptom severity. It's also thought that potentially cannabis can offer potential to stimulate neuroprotective mechanisms while decreasing the neuroinflammation caused by the buildup of amyloid proteins in the brain. And then for autoimmune disorders, cannabinoids, as we know and have heard in this presentation, have an anti-inflammatory and immunosuppressive activity. And so there is thought that potentially it can aid in treating or at least helping alleviate symptoms in many autoimmune disorders. So now we're going to switch gears a little bit and talk about current law and policy. So in 1996 is where we really started seeing medical cannabis kind of come alive in the United States. So California was our trailblazing state. They saw their medical cannabis laws go into effect in 1996. On January 1st of 2014, Colorado became the first state to permit cannabis dispensaries to basically sell recreational cannabis. So we saw Colorado kind of leading the way in 2014 in that aspect. There are a total of 33 states, including the District of Columbia, Guam, Puerto Rico, and the U.S. Virgin Islands, that have approved comprehensive medical cannabis programs. There are some states that have low THC programs, where the use of low THC, high CBD products are allowed for medical reasons. And as of mid-2019, we had 14 states and territories that had approved adult use, which is also synonymous with the word recreational, cannabis programs. But as most of us know, and important to remember, that at a federal level, cannabis remains classified as a Schedule I substance under the Controlled Substance Act. This is an image from 2018, just to kind of give a breakdown of states with the adult use and medical use programs, and just medical programs, and states that have no programs. So as you can see, Missouri is kind of in that Kelly green color, meaning that we do have a comprehensive medical cannabis program here. We do not have recreational or adult use programs here in our state. But we will talk a little bit more about our medical program. So Missouri Constitutional Amendment number 2 is really what opened the door for Missouri to have medical cannabis. This was passed by public vote in November 2018. And this is what gave Missouri citizens the right to access medical cannabis. So Amendment number 2 permits state licensed physicians, that includes MDs or DOs only, to recommend cannabis for medical purposes to patients with serious illnesses and medical conditions. It allows patients with qualifying medical conditions the right to discuss freely with their physicians the possible benefits of medical cannabis use. It gives the right of their physician to provide professional advice concerning cannabis use, and it gives the right to use medical cannabis for treatment under the supervision of a qualifying physician. So patient requirements. Patient must have an eligible qualifying medical condition to be a candidate. And I have there the actual text from the amendment itself with the conditions that are listed. But as you read through that, you will note that the last line says that a condition whose treatment with prescription medications may lead to a dependency or any other chronic debilitating condition deemed qualifying by a physician. So the line with any other chronic debilitating condition deemed qualifying for a physician really opens the door for physicians to kind of decide for their patients, if their condition qualifies them or not, without specifically being listed in the law. Qualifying patients or their caregivers, Missouri does allow a caregiver, must obtain an ID card from the Department of Health and Senior Services. At the time of creating this presentation, the cost was $25 annually or $100 annually if the patient planned to grow their own plants. It's a 12-month valid card. They have to renew it annually, and they have to submit each year a new updated physician certification. Those certifications must be no less than 30 days old before submitting. So under Missouri's law, a patient can purchase up to 4 ounces or less of dry, unprocessed cannabis or its equivalent every 30 days. And they cannot have more than a 60-day supply on hand at a time. So they must actively be using this to treat their condition. If they are deciding to grow their own plants, they may cultivate up to 6 flowering cannabis plants for personal use. And patients may not consume medical cannabis in public spaces. To be a prescriber who would like to certify patients, you must be a physician licensed and in good standing to practice medicine or osteopathy under Missouri law. Physicians must complete a physician's certification form for each qualifying patient, and this form must be completed within 30 days of a patient applying for an ID card. So that rule falls on both the physician and the patient's shoulders to make sure that they are getting that completed in a timely manner and submitted. If a patient is under the age of 18, they can still be given a card, but they must have written consent from a patient's parent or legal guardian to recommend the medical cannabis and certify that patient. So when Missouri established our Amendment 2, the state awarded 192 cannabis dispensary licenses. That was the minimum amount of dispensary license that were going to be allowed per the amendment, and the state awarded the minimum amount. They believed that this number of dispensaries will meet the demand for medical cannabis in Missouri. We expected a lot of these dispensaries to be opening in January 2020, or I'm sorry, in the spring and summer of 2020. We all know what happened in 2020. We had a global pandemic that is still occurring today. So we really didn't see a lot of dispensaries opening until late 2020. And even to this day, we're still seeing new ones pop up. So slowly but surely through 2021, we've been seeing dispensaries open throughout St. Louis and throughout the state. So we're still kind of getting everything open and going to this day. And one interesting little fact, dispensaries can only obtain cannabis grown on Missouri farms. If you think about it, we're still a Schedule I substance at the federal level, so you cannot be transporting the cannabis across state lines. Okay, in summary, cannabis prohibition has a long-rooted history in the United States, which mostly was created by fear and an overall lack of knowledge. States have begun to take control over medical cannabis regulation, but we must still remember it is a Schedule I substance on the federal level. Cannabis is not a one-size-fits-all medication. Its recommendation will vary widely from patient to patient based on preferences, current medical conditions and medications, and the legislature in which the area they reside. I think it's important to make sure that for pregnant and breastfeeding patients that we are recommending cannabis to not be used during this time. And it's important to know too that cannabis does have adverse effects and drug interactions. It's not, it's not something that comes without any risk. So those really should be taken into account when making recommendations and educating patients. Overall, the best method in regards to dosing when recommending medical cannabis is to start low and go slow. And it's important to note that due to federal regulation, you can't prescribe cannabis. The physicians that are certifying patients can only recommend cannabis and cannabis products for their patients. So that ends our presentation on medical cannabis. I hope that this was a good kind of overall quick look at medical cannabis for you to really dive deep into some of these mechanisms and different aspects about cannabis. We could be here for much, much longer. So I hope this was a nice overview into different aspects regarding medical cannabis. But if you do still have questions or want any any information about the program I attended and got my master's through, or just have a general question, you can email me at lpalmier, Pharm.D at gmail.com, and I will get back to you hopefully with an answer. Thank you so much.